Good afternoon, everyone. Welcome to our Queen Elizabeth Scholarship webinar. We're coming to you from the McMaster Health Forum at McMaster University in Hamilton, Ontario, Canada. This is the third in a series of webinars we'll be conducting by our Queen Elizabeth Scholars. I'm going to give you a quick little summary of the McMaster Health Forum, the Queen Elizabeth Scholarship Program, and then I'll introduce you to our incoming scholar, Joycelyne, who is coming to us from Ghana, and her presentations on addressing maternal, newborn, and child health issues in Ghana. If you have any questions, I ask that you please wait until the end of the presentation and use the chat box for those that are online. The McMaster Health Forum is a leading hub for improving health outcomes through collective problem solving. It harnesses information, convenes stakeholders, and prepares action-oriented leaders. It acts as an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between Rideau Hall Foundation, Community Foundations of Canada, Universities Canada, and Canadian universities. The purpose is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The Queen Elizabeth Scholarship Program at the Forum has a focus of strengthening health systems, which means that our scholars will contribute to strengthening health systems and become part of our large and growing network of health system leaders. Here's a list of the Forum's Queen Elizabeth Scholars, 13 in total and counting. With more to come very soon. All of these scholars will be producing a webinar just like the one that you are watching today. So take a look at our website to get a full list of the upcoming webinars. Today is by incoming Queen Elizabeth Scholar Joycelyne, who is a citizen of the Commonwealth country of Ghana. She is currently a PhD candidate in the Health Research Methodology Program at McMaster University. With the help of her supervisor, she aims to develop new methods for analyzing data from interrupted time series design, which is the most common quasi-experimental design utilized in implementation science. Her work in Ghana focused on identifying the risk factors for the three major childhood illnesses, diarrhea, fever, and pneumonia, in Ghanaian children. Warm welcome to Joycelyne.
Thank you, James. Good afternoon, everyone, and thanks for joining us for this webinar. And my presentation this afternoon is going to be on maternal, newborn, and child health issues in Ghana. There are various ways of strengthening health systems, and which includes ensuring that targeted programs are integrated into the national health system, and also ensuring that there is improved access to healthcare delivery services. Going a step further to that is to find out how the various programs, so how the various strategies that have been put in place to increase or to improve our health system or to strengthen the health system have come so far. For instance, if there was a program related to maternal and child health, we'd like to know how the program has impacted on improving maternal and child health issues. And that is what my presentation is going to be about. I'd like to also note that this is part of some ongoing projects we are currently embarking on. And for this afternoon, I'm going to concentrate on child nutritional status in Ghana. If anyone is interested in knowing more about maternal and newborn and other health issues that we are working on, you can gladly contact me on my email and we'll talk more about that. So before I proceed, I just want to give a brief background information about Ghana. Ghana is located on the African continent, specifically in the West African region. So as we can see, the arrow pointing to Ghana is bordered on the west by Côte d'Ivoire, on the north by Burkina Faso, on the east by Togo, and on the south we have the Gulf of Guinea, which is a tropical part of the Atlantic Ocean. So this gives us a clearer view of Ghana. It's divided into 10 administrative regions. The capital city of Ghana is located in the Greater Accra region, which is the second region to the right along the coast. Technically, we can say that Ghana is divided into three main sections: the coastal areas, which includes the four regions that lies out along the coast; the middle sector, which is a lot more of the vegetational areas; and then the northern areas, which is a lot more of the savanna areas. So for people who may be interested in the future to go to Ghana to pursue their QE program or project, I have a few pictures here for you to see. So this is a typical beach along the that can be found in the coastal part of Ghana. For those who love beaches, I think you would find this interesting and exciting. For those who like to hike, the middle sector has some highlands, although Ghana usually is a low-lying land. There are some highlands in the middle sector, and Afajato is the highest elevation point in Ghana. So for those who love to hike, this is an interesting place for you to visit. And finally, in the savanna areas, which is usually in the northern part of Ghana, there are some national parks and wildlife reserves for those who enjoy the natural sites or the natural scenes. This is an interesting place for you to go visit anytime you go to Ghana or decide to pursue a program or your project in Ghana. So I have some fun facts here about Ghana that I'd like to share with you as well. There are over 70 major dialects and languages spoken in the country. Our average temperature is about 26 degrees Celsius, so it's much hotter than the average temperature here in Canada. It is the first country in the sub-Saharan African region to gain independence. Some parts of the Greenwich Meridian, which is the longitude 0 degrees that divides the world into east and west, goes through some parts of Ghana. So we are on the Greenwich Mean Time. And the most interesting part, which I said for last, is that it has the largest man-made lake in the world, which is the Lake Volta. So for some basic demographic health indicators, the population is about 27 million with an annual population growth rate of 2.2%. It is a young population with about 40% of the population being under 15 years of age and only 5% of them being 65 years and older. The median age of the population is 20.8 years, which is approximately 21 years. And then the life expectancy at birth of male to female is 61 years to 64 years. Our birth rate per 1,000 population stands at 31.4, and the under 5 mortality rate, that is the number of deaths per 1,000 live births, is 61.6, or 62 deaths per 1,000 live births. The maternal mortality rate is also 319 per 100,000 live births in the country. And our total health expenditure is about 3.6% of the national GDP. So before I proceed to my main project, I just wanted to give a brief overview of the health system in Ghana. So at the topmost level, we have the Ministry of Health, and which controls the Ghana Health Service, which is the next level. The Ghana Health Service is technically an independent body or organization, and this is because it's the government tried to give it some sort of flexibility in carrying out their responsibilities, but it is under the control of the Ministry of Health. The Ghana Health Service is administratively conducts its functions in 3 levels. So at the national level, at the regional level, and then at the district level. But functionally, their district level is also divided into the sub-district level and then the community level. And all these work together to help improve the health status of the population. The Ghana Health Service, together with the Ministry of Health, has embarked on a couple of projects to help improve the health in the population, and these include the National Nutritional and Malaria Control for Child Survival Project, as well as the Newborn Care Program. One of the main issues of the Ghana health system is related to maternal and child health, and that is not just related to Ghana, but then in most developing countries, as we can see. So now I'll go on to my presentation. So maternal and child health, as I just mentioned, is a relevant public health issue and a major problem, especially in developing countries, of which Ghana is one. So in view of this, there's been a lot of policy attention given to it by several international bodies, and including the WHO, the UNICEF, and then the United Nations. So one main policy that was implemented, or that was rolled out, was the United Nations Millennium Development Goals. And specifically, I would like to concentrate on Goal 1C, Goal 4, and Goal 5. So the main aim of these goals were to reduce child malnutrition, which is an indicator for poverty eradication, to reduce infant mortality, as well as to improve maternal health. So in order to attain these goals, there's been strategies that have been rolled out or implemented by both government and non-governmental agencies over the years. And some of these interventions include the National Health Insurance Scheme, which included a free delivery system, the Infant and Young Child Feeding Program, the Community Health Planning Systems, as well as the maternal and neonatal health care. There was also the school feeding program, which was implemented a couple of years ago to help achieve these Millennium Development Goals. All these interventions have been rolled out in the past couple of years. As a result, one main question that is of interest to stakeholders and researchers throughout the years as these interventions have been implemented is that what is the impact of these interventions on maternal, newborn and child health? So as in, has these interventions improved maternal and child health? If it hasn't improved, what are the shortfalls? What can be done as in going forward in order to ensure that there is an increase or improved maternal and child health is improved? So that brings me to the rationale of my study. Usually, national and regional estimates of several of these indicators of maternal and child health is known, such as the prevalence of maternal malnutrition, the prevalence of child malnutrition. At the national and regional levels, most of these are already known. What the disadvantage or one shortfall of these estimates is that they may conceal important disparities among particular subnational groups or sub-demographic groups. For instance, if we know that the overall malnutrition prevalence is like 60%, it does not tell us, there could be that within particular subgroups of the population, for instance, people who are aged 30 to 34, the prevalence of maternal malnutrition could be as high as 80% or even as low as 20%. So if we just consider the national estimates, we might miss these disparities among these various subgroups. There's also the increased likelihood of missing target areas, especially when you want to roll out an intervention. You miss these target areas with specific needs. Another important factor is to identify the various variables associated with overall malnutrition, since this is relevant in prioritizing interventions and also tailoring interventions towards the needs of the people. So this study was conducted to assess the nutritional status of children under 5 years in Ghana. So our main objectives were to examine the prevalence of child malnutrition and anemia among different socio-demographic subgroups in the country, as well as identify the risk factors associated with overall malnutrition and anemia. So to help us achieve our aim, we divided the factors into child, maternal, and household factors. So under the child factors, we looked at various variables such as the age of the child, the sex of the child, and whether the child has a comorbidity disease. With the maternal factors, we looked at the highest educational level of the mother, the nutritional status of the mother, and the occupation. And then under the environmental factors, we concentrated more on the type of residence, that is, whether the household is in an urban or rural area, the region of residence, and then their source of drinking water, and etc. So for this analysis, we used the 2008 Ghana Demographic and Health Survey. We used this 2008 data because as at the point of conducting this analysis, that was the recent available data to the public. So overall malnutrition was measured by 3 indices: stunting, which is low height for age, when you are too short for your age; underweight, which is when you are too thin for your age; and wasting, when you are too thin for your height. Anemia was measured by the hemoglobin concentration in the blood, which was a variable available in the Demographic and Health Survey data. So to give a brief summary of our data that we used, there were approximately 2,300 respondents, or children, which we call respondents in our analysis. It was evenly distributed between males and females, with about 50% being males and 50% being females. The average age of the children or the respondents was about approximately 29 months, which is about 2 years. And about 67% of our respondents were resided in the rural areas, while 33% were resided in the urban areas. So before I go into the subgroup analysis, I just wanted to show the trend of malnutrition and anemia over the years. So if we look at the first figure A, which shows the prevalence of malnutrition between 1998 and 2008, we could see that for underweight and wasting, it has been a consistent decrease over the years. However, for stunting, we could see it increased slightly between 1998 and 2003, and then decreased again between 2003 and 2008. When we look at the prevalence of anemia, however, prior to 2003, there was no data available on hemoglobin concentration, so we couldn't calculate anemia prevalence. However, when we look at the 2003 and 2008 data, we realized that there was a slight increase in the prevalence of anemia from 76 to 78%, which was interesting in a way that we would like to know how this came about and what they were missing over the years. When we look at if we look at the severity of anemia as well, we realize that the trends did not differ much. So for analysis, we found out that approximately 35% of children in the Ghanaian population were malnourished, and most male children had a higher likelihood of being malnourished compared to the female children. We also found out that the highest malnutrition prevalence was in male children who were a year old, that is between 12 to 23 months. And the lowest recorded prevalence of malnutrition was found in female children who were less than 6 months of age, which is just about 19%. So we went further to look at the prevalence of malnutrition between these subgroups and compare the urban areas with the rural areas. As we can see, I'd like to note here that the y-axis in the two graphs are slightly different. So if you just look at the figure, it might be a bit misleading. But then the numbers on it show that overall, the rural areas had a much higher prevalence across all forms of malnutrition compared to the urban areas. And this is not surprising, looking at the disparity between the rural and urban areas in terms of the socioeconomic status, access to adequate food sources, access to adequate and improved health care and such. One interesting thing we found was that in the older urban children, that is kids who were 36 months of age and above, the prevalence of wasting was actually slightly higher in the urban areas than in the urban children than in the rural children. And this we thought was very interesting. The only hypothetical reason I can think about for this is that the rural areas have a higher infant mortality rate, so the children are less likely to grow to the age of 5, so then makes the urban children, older children population much higher, and hence a much higher chance of being wasted. So looking at the prevalence of anemia, we found out that it was more prevalent in children who were younger, that is less than 2 years of age, than in older children. Similar to the prevalence of overall malnutrition, children in the rural areas were more likely to be anemic compared to their urban counterparts. The highest prevalence recorded in the rural areas was 90%, and that is for children who were less than a year old. And the highest prevalence recorded for children in the urban areas was about 80%, which is relatively lower than children in the urban areas. We also looked at the prevalence of anemia by region, and here the color spectrum just shows us the prevalence rates across the entire region. So the very red regions are the regions with really high anemia prevalence, and the green regions are regions with a relatively lower anemia prevalence. So the Upper East and West recorded the highest overall prevalence, approximating about 90% in the region. The lowest overall anemia prevalence was recorded or was found in the Greater Accra region. When we looked at the age subgroups within each of these regions, we found out that in the Greater Accra region, where the regional estimate was 62%, the prevalence ranged from about 80% or 79% in children who were a year old to about 54% in children who were older, so about 3 to 4 years of age. And this goes to emphasize my initial point that when we just look at regional estimates, we might miss the disparity among the subgroups. For instance, here, the Greater Accra regional estimate of anemia prevalence is just 62%. But when we look at subgroups within the region, about 80% of children who are a year old are anemic. And this is something we may have missed if we didn't consider the subgroup analysis. We also found in regions such as the Volta and Upper West region, the prevalence of anemia was about 98% in children who were a year old. That is really alarming because it goes to show that almost every child in that region is anemic. And this shows that they need urgent care or urgent attention. So to give a general overview of our findings, the prevalence of stunting was mostly higher in children who were 2 years of age and older. And this was not very surprising because stunting is usually cumulative effects of certain nutritional shocks that happens over the years of the child. So it's more likely to be realized or prevalent in older children than in younger children. The prevalence of wasting and anemia was also higher in children who were younger, that is, who were less than 2 years of age. And one reason that we found for this could be that most children in this age range, that is lower than 2 years, are being introduced to complementary feeding. So this might affect their food, their nutritional intakes, and since the food choices come from the mother, anything that they are given that is lacking in most micronutrients might affect their overall development. The other reason could be due to infections at that age. If they are infected at that age, it might affect the kind of their eating patterns. And wasting is a measure of being too thin for your height. It could be just for the short period that they were not eating properly and hence were not growing properly. As I mentioned, the prevalence of wasting was higher in urban children than in the older children than in their rural counterparts. When we assess the significant risk factors of overall malnutrition, we found several risk factors, but the main ones, significant ones, was the age of the child, where the children in particular age groups were more prone to developing or having some forms of malnutrition. The next risk factor was the educational level of the mother. We found out that mothers who had higher education or higher than secondary education were less likely to have malnourished children. Lastly, financial status of the household, where households higher income households were less likely to have malnourished children compared to low income households. When we went further to look at the prevalence of malnutrition by financial status within the regions, we realized something interesting here, that for some regions, such as the northern and western regions, childhood malnutrition was not limited by the financial status of the household. That is, children from both low income and high income families were all malnourished. And this made us realize that there might be other important factors other than the financial status that is affecting the development or the nutritional status of these kids. And that needs to be looked into. In the next two slides, I just want to give you what the trends are currently. The 2014 data became recently available. The demographic and health surveys technically conducted every 5 years in the country. So the recent one, which was conducted in 2014, became available, and I just looked at what the trends have been over time. So these are the national trends. We could see that there is some improvements, which is very encouraging, which shows that the interventions may have been working now, or it shows that interventions that were rolled that probably took time to take effect, but then the effect is a lot more prominent now. I also wanted to look at the prevalence among the different age subgroups, and overall we could see that the prevalence has actually decreased for all forms of malnutrition as well as anemia, which is also very encouraging. So what we are currently doing, or what we would like to find out now, is how has it improved in the various subgroups we considered using the 2008 data? Because as I mentioned earlier, just looking at these national estimates, overall estimates, is not enough. We want to see whether interventions actually targeted the people we found to be highly malnourished and how it has improved their health over the years. So in conclusion, I would like to say there's been great efforts made to improve maternal and child health by reducing indicators such as child malnutrition, because overall we could see that there's been a decline. However, there's more work needs to be done to improve access to healthcare, especially to maternal, newborn, and child health care, since these might help us to reach the targets or our target goals. The key challenges that were found include the inadequate national data and reliable information on maternal and child health. As I mentioned, the demographic and health survey is conducted every 5 years. So within that time, I think it's better for us to have some survey either every year or every other year, so we can frequently monitor most of these indicators to see how interventions are working and what needs to be improved. Another major challenge is the differences in socioeconomic and sociocultural factors, which includes the high rate of female literacy, low rate of female literacy, low rate of women employment, as well as various cultural beliefs. So when we found out that even in some regions, children from both high income and low income families were malnourished, we realized that some of it was also due to their cultural beliefs. These might prevent them from giving their kids the right food, or some cultural beliefs might affect parents seeking adequate health care for their kids when they are sick. So going forward, what are the future directions? I think interventions should be a lot more knowledge in a form of knowledge translation, or knowledge translation interventions are required a lot more, and this could include educating parents and caregivers on the right foods to give their wards. So parents must know that it's not just about giving them the food, but giving them the right kind of food and in the right proportions. It's also important that interventions target the right populations, and this is key when you don't just look at national and regional estimates, but also look at the subgroup estimates to see the areas or the groups with urgent need and how to tailor your interventions to meet that need. And that is tied in with stakeholders getting the right data and being educated on the importance of evidence-based decision making. So if all this comes together, we can improve maternal and child health in Ghana. And thank you. So before I end, I'd like to thank a few people. I'd like to thank my supervisors, Dr. Hamid and Dr. Strauss, for their immense support and supervision and mentorship. I'd also like to thank McMaster Health Forum and the Queen Elizabeth Scholarship Program for giving me this opportunity to learn more about ways to strengthen our health systems. And also thank my co-authors. As I mentioned, this is part of a series of projects. We already published 2 papers, so I'd like to thank my co-authors for helping me with that. And to all those who helped in this project, I greatly appreciate all your contributions. My references, and thank you.
Thank you very much, Joycelyne. Don't go anywhere. So we'll open it up for questions. So we have some people online. If you have a question online, please type it into the chat box. For those of us in the room, then we'll go around and give you the opportunity to ask questions in a second. So I'll start things off with a quick question. So it looks like, at least in a short period of time, what the government has been doing to alleviate these issues is slowly starting to work. So could you maybe give us a quick little summary of what are the types of things the government implemented to try to help these malnutrition and anemic issues?
Oh, yeah, sure. There's been several interventions, as I mentioned, like the infant and young child feeding program. They recently came up with a community planning and I think community planning and help centers or helping services, which is known as the CHIPS compound, to improve healthcare delivery. There are several maternal and neonatal programs going on currently. And there is, for anemia, I know there was some iron supplementation interventions that were rolled out over the years. So I think all these helped to improve or alleviate the issue, and now we can see the improvements in 2014.
Great. So then as a follow-up question then, to put on my health systems hat for a second, so when the government in Ghana goes to implement these types of changes across the country, how easy is it in terms of the system level for them to implement across the country in all of the different regions? Are there different, are there barriers in any of those areas, or do they all work well together, or are there different strategies that have to be put in place for those different spots in the country?
Generally, I think it works well because they don't just operate at a national level. They have the regional sectors and the district level, and then sub-districts and communities. So I think in most of these sub-districts and communities, they have the health centers that helps because they are in direct contact with the people in the community. So if there is any barrier, it's easier for them to implement these interventions than for someone elsewhere coming in to come and implement it. So I think usually they work with the local people in the best possible way they can to help.
So it's kind of a grassroots, from the ground up implementation strategy that they tend to employ? Perfect. Any questions? Again, if you're online, if you have a question, feel free to type in the chat box. Any questions from anybody in the room? Yeah. So for the people online, if you didn't pick that up, so basically the question relates to going forward and how to use this multiple data points in terms of analysis. So I think that's part of your PhD work, right? So an interrupted time series to link these different points and the interventions that the government is implementing. So maybe you could just comment on where you're going to go from here.
Yeah, exactly. Thanks for saying that. It's as I mentioned, this is part of an ongoing project. So that is one main thing we want to look at after looking at the 2014 data, to kind of see how the trend over time, to see when these interventions were implemented and how it has actually impacted on improving these issues, and whether. Yeah, and the other reason too is to find out if it's actually due to these interventions or just due to the other factors that no. So that is something we are considering, or that is part of our objectives in this line of project. So thanks for mentioning it.
Thank you. Any other questions? So the question for those online, if you didn't hear, it's a two-pronged question. So the first part of it being the cultural factors that may influence some of the outcomes that we've seen here, especially in relation to anemia, and then what educational programs the government has put in place in order to help with these issues.
So thanks for the question. That was a really good one. The cultural factors. So off the top of my head, I can think of this. In some areas, they don't believe in giving children some kinds of food when you're a child, for example, meat. But then these are the kind of things that meat, for instance, has high iron, is highly, what's the word? I don't even know the word to use. There's a lot more iron in meat. So for instance, if you don't believe that your child is supposed to get meat, then obviously you are preventing the child from getting this. And these are some of the cultural factors I talked about that might affect anemia prevalence. So going forward, I'm not very sure about this, as in what the government is doing currently, but I believe, as I mentioned, that parent education or caretaker education is very important. Those who are taking care of these kids or their parents must know that iron is very important, especially for anemia, since it's iron deficiency anemia. Iron is really important in the health of it, to help the development of the child. So it's important for them to give them these kinds of food, even if you don't believe that a child should eat, for instance, meat because they are too young. It's better for them. It's very key that we educate these parents on the importance of giving meat to their kids, irrespective of their cultural behaviors. And I think the best way to do this, I think, is to target the community leaders or opinion leaders in the community and let them understand the importance of child nutrition, and that way they can easily relate to their people.
Thank you. Any questions? Again, any more questions online or anybody else in the room? Let's see, there we have a question online. Let me read it out for you. Do you mind explaining more about how the government goes about introducing national interventions of these problems, or does each of the regions create their own programs to meet the needs of that specific population?
So thank you, Christy, for your question. How the government goes about introducing these national interventions. They introduce it basically at the different levels of administration or functions, as I mentioned. So nationally, there might be adverts on TV or on radio about the interventions being rolled out. And then when you go into the regions and the districts, they have, I believe, interventions tailored towards the particular region or the particular district to help this. So the government mainly takes lead in most of these interventions. And as to the regions taking their own interventions, I'm not so sure, because most of them are under the national level. So whatever they do is based on information or instructions from the national level.
Thank you again, Joycelyne, and thank you for the question from our online audience. So I'll go back to my question then. Basically, now that you've lived and worked and studied here in Canada, what do you notice as the main difference from a system perspective between how we run healthcare in Canada and how it's run in Ghana? It's a loaded question. I apologize.
Yes. How we run. I think here it's a lot more decentralized. I don't know if that's the right word. So, for instance, Ontario province takes care of its own health compared to like province in Alberta and such. But then in Ghana, it's all centralized. So it's like the main points, for instance, in Accra, which is the capital. So whatever the regions do, as I was answering Christy's question, is based on instructions or what they've been told from the national levels. So I think decentralizing will be good in terms of future for Ghana, because that way regions can take care of their own people or the health of their own people and roll out interventions or come up with projects that would help their people, not just at the national level, but also within the regions and within communities or districts within the regions. And it's easier to help alleviate this issue and target more people.
Thank you very much. We have another question in the room. Go ahead. Really a question for those that are online. It was more of we just happen to have somebody in the room from another African country who was just mentioning that the challenges of decentralizing in many African countries may actually be at a detriment as opposed to helping them in terms of a lot of different issues that may arise from governance to financial structures and on down the line. So Canada being a very different structure suits Canada, may not necessarily suit other countries, especially in the African continent.
Thank you.
I get that? Yep. The room is basically about who are the main drivers around these innovations in terms of policy when it relates to healthcare. So is it external agencies that may come into the country and make suggestions? And based on your presentation, Joycelyne, it sounded like a lot of this came out because the World Health Organization and the UN said that this should be something you should be focusing on. Or is this are the drivers internal? Are they things that the people are saying we need these types of changes because we see these issues happening within our population? So external versus internal drivers of healthcare policy is the short version of the question. So what do you think?
Question, comments. Yeah, so it's not really, I don't think what she said was really a question, it's more of a comment. And I believe it's mostly both. Like, although there's a lot more external drivers from these international bodies, there are some, the government or then at the national level, there are some interventions that are also being rolled out, but majority of it is external, and most of these is due to funding, I guess.
Great, well, thank you. Thank you for everybody in the room. Thank you for those online. I'll pause for just another few seconds to see if anybody else has any questions. If you're online, feel free to use the chat box. And otherwise, I'll just say thank you for those of you who joined us here in the room in the McMaster Health Forum. Thank you for those who joined us online. And thank you, of course, to Joycelyne for doing her presentation for us. I have some links on the screen there for those who are interested in the Queen Elizabeth program here at the McMaster Health Forum. That first link will take you to the information about the program itself. The second link is a list of all of our webinars with links to all of our Queen Elizabeth scholars, links to their videos. Once they're finished their webinars, all of them are recorded and uploaded to YouTube. They all write a blog for us. So that third link is actually a link to our blog site where you can read their blogs once they're posted. And otherwise, thank you again, everybody, for joining us, and look forward to seeing everybody again at our next webinar for our next Queen Elizabeth Scholarship Program. Thank you.